time for Back to Life, brought to you by Southwest Spine and Pain. A 30-minute conversation with their board-certified physicians about how to live life again, pain-free.
Welcome to Southwest Spine and Pain Back to Life show. Our host today is Dr. Derek Frieden. He's going to be discussing the role of injections in treating acute and chronic pain. Welcome, Dr. Frieden.
Thank you, and thank you for having me back again. It's always good to be here.
Would you like to start out by maybe explaining the difference between acute and chronic pain?
Sure. So acute pain is typically defined as 6 weeks of duration or less. So these are muscle sprains, strains. It could be a disc herniation. Oftentimes, that type of pain will get better by itself with some ice, heat, stretching, physical therapy. Once we get to about 6 weeks, we're in that intermediate phase where if they're not improving, they probably should come in and be evaluated, see a specialist. If the therapy hasn't worked, some ice, heat, stretching, ibuprofen, that's a good time to get evaluated because what we're trying to prevent is from that pain getting into the chronic pain phase. Once we've reached around 12 weeks, now we're in more of a chronic pain phase where we start to see changes at the microscopic level in the spinal cord and the nerve fibers, and that pain becomes somewhat more difficult for us to treat. There's also another class of pain, which is cancer pain, and that's somewhat self-explanatory. You know, folks that have different types of cancer, whether it's due to pressure on the nerves or pressure on the organs, or post-radiation or chemotherapy, we'll see patients that have that type of pain as well.
Why don't we talk for just a few minutes about how you do treat the acute patients and maybe give an example?
So an acute patient would be someone that either refers themselves or they've seen their primary care doctor and their pain's not responding to ibuprofen or stretching. And that may be a patient that suddenly notices pain in their back or pain radiating down into their leg or neck pain into their arm. Often that'll be to a disc herniation. Patients often ask me what caused the herniation, and the majority of times there is no underlying cause. Sometimes it's obvious. They'll tell you, I was lifting a trailer up and I felt a pop and I felt the pain down my leg. Then it's fairly obvious what caused it. But most of the time, it just suddenly starts. They notice a tingling or a pain down their leg. What I tell my patients is the disc, when we're young, is somewhat soft and pliable, and as we age, it becomes a little more brittle. The analogy would be like the rubber on your windshield wipers. One day it looks perfectly fine. The next day you go out, nothing happened, but you start to notice little cracks in the rubber.
Well, that's a good example.
And with the disc, there's a constant pressure on the central part of the disc, and when we get those little cracks, the pressure can cause the disc to herniate out into the spinal canal, and then it starts to put pressure on the nerve itself. So somebody that's suffering that, depending on how severe it is, if they come in and it's a mild to moderate discomfort, we might refer them to physical therapy, traction, stretching, give them a muscle relaxant and see how they respond. If that doesn't improve the situation, then they would likely be a candidate for a steroid injection, whether it be an epidural steroid injection or what's called a transforaminal epidural steroid injection. And those are just two separate methods of getting the medication around the area of interest or where the nerve is being compressed or irritated.
And then for the chronic pain, can you give me an example of that? Can you give us an example?
Yeah, for chronic pain, and there's a whole host of causes of chronic pain. Again, someone with cancer pain that's past 12 weeks would still classify as chronic pain. A lot of chronic pain patients that we see will come in and say, Doc, I've had this bad back for years. And either my wife's tired of hearing about it, or I'm tired of living with it, or it's just progressed to the point where it's starting to affect my, ability to do the things I want to do. So with that patient, often there won't be ridiculous symptoms or pain radiating down into the legs. It may be just arthritis in the small joints of the spine that we call the facet joints. And those patients will get some x-rays. Again, we'll see if they've tried therapy. Oftentimes they've seen a chiropractor, done therapy, tried massage, a whole host of different things, and it's just not getting better. So once we review the x-rays to make sure there's no instability or tumor or something that's more of a serious nature, those are patients that will often numb up the small nerves to those joints and see if the pain goes away. The pain won't go away for very long, but the fact that the pain resolved for an hour or two tells us that those nerves are carrying the pain signal. Those patients do well with a procedure called radiofrequency ablation. That's where we bring them back. It's an outpatient procedure. It takes 10 to 15 minutes. We numb the skin. We place a small needle under x-ray guidance, and then we target that small nerve that's about the size of a hair fiber, and then we apply heat, and we can cauterize or burn that nerve, and that'll stop that pain signal and therefore provide relief for usually about 9 months to a year. The pain will generally come back as the nerve regrows, as we haven't found a way to stop that from happening yet. So we'll see a lot of patients that come in once a year and they'll say, hey, doc, I was doing great, but that pain that I had has just slowly returned and it feels just like it used to. We won't have to retest those patients. We'll just schedule them to come back and then we'll go in and repeat that procedure.
Now, with that procedure, can you do it for years? Can you have a repeat once a year for years to come?
It's indefinite. I've got patients now that I've seen for 10 years and they come in and see me every year. And then there are other patients where it may get to the point where it doesn't work. Often there are underlying issues that may progress. So they may have underlying spinal stenosis or narrowing of the spinal canal that has progressively worsened over the years. They may have a new disc herniation. The discs may degenerate, and there may be other sources of their pain that the radiofrequency isn't addressing.
Is it important to get an MRI as well as x-rays when you're working with your patients?
So it depends on what they present with. Typically, if they present with pain that doesn't have radiating pain, such as back or neck pain that doesn't go into the legs or the arms, that's usually more a mechanical type pain that's involving the joints. So typically we'll start with an x-ray to make sure there's no movement or instability, a tumor, a fracture, something of that nature. If they have pain that's radiating, then typically we'll get an MRI because usually a disc is suspected as causing that discomfort or pain.
And if they have disc injury, would you consider that? You'd consider that acute, something that can be repaired within 6 weeks? Usually
it starts off as an acute injury, and if we don't address it, it can progress into a chronic type injury. So it's reasonable to try a few weeks of conservative therapy if they can tolerate the discomfort and participate in what we call their ADLs or their activities of daily living. If a patient comes in with pain radiating down the leg or the arm to the point where they can't shower, bathe, they can barely move because of the intensity of the pain, then we'll inject those patients earlier to try and cool off the inflammation around the nerve root. Then once we get the pain under better control, we'll send them for physical therapy, anti-inflammatory type medications, muscle relaxants. Sometimes if we get early enough and we do an injection or two, we can get the inflammation down, resolve the pain, and they don't have to go on and do anything else. We release them and they go back to living their life, and they do quite well.
How serious is the sciatica nerve as far as, and how easy is it to treat, or how difficult is it to treat?
It often depends on the size of the herniation. If it's a mild to moderate herniation, then usually I'd say 70 to 80% of the time we can get the pain under control where we can avoid surgery. There are some herniations that are so big, often I'll see that patient, I tell them surgery is going to be likely. We'll do an injection to try and get you some relief, but we're going to get you up and to see the surgeon because in my estimation, this disc is probably going to have to come out. One thing with a large disc herniation that's always what we call a red flag or a need for more serious attention would be if they're losing function of their bowel or their bladder, or if they're retaining and unable to urinate. That would be a sign that there's too much compression on that nerve root, and they should probably see a surgeon sooner rather than later, sometimes even to the point where they need to go to the emergency room and have surgery that day.
Do you see a lot of patients that surgery is necessary, or is that pretty uncommon?
No, I'd say well, we see a mix. We've had some patients that have had surgery, and they'll tell me, my leg's doing a lot better, but my back is still an issue. Obviously, the patients that have surgery and do fantastic, and there are those patients, we don't see them because they're doing well. Mm-hmm. 70 to 80% of the time, I think if we get involved early enough, we can avoid the need for surgery. Nobody wants surgery, but we have some excellent surgeons in the region, which is great because when I moved here in 2005, we had surgeons, and they were good surgeons, but they traveled from Las Vegas or Salt Lake City. They weren't really here and part of the community, and once they operated, they would leave, and if there was a problem, it was harder on the patient. But now we've got great surgeons in the community. They do a great job, and for those patients that we can't help, we're able to get them to the surgeons. And what I tell my patients, it doesn't really matter who gets you better. What's important is that you get better. So whoever the resource is for that to happen, that's who we want to get you in and get you seen by.
Oh, absolutely. So as far as what areas, maybe we could talk about some of the kind of conditions that you work with and how you treat them.
Yeah, so there's a wide range of problems that we treat. We've touched a little bit on the arthritis of the spine for the neck and the back. That's a fairly common problem we treat. Sciatica or radiculopathy, we'd call it, cervical or lumbar, whether it's from the neck or the back. Those are very common ailments that we treat. Another common one is what's called SI joint pain, or it stands for sacroiliac joint arthropathy, and that's a long, slender joint in our low back. If you press back there, you can feel a small dimple, and that joint transfers most of the weight from the upper body through the pelvis and into the hips. Be quite debilitating and uncomfortable if it gets inflamed or irritated. Often a small injection into that joint will provide fairly significant relief. So we were going to discuss a little bit about the role of the injections, because often patients will come back and say, "Doc, I had that shot and it didn't help." So we have to often dig in a little further, because I'll have a patient, let's call her Betty, will come in and say, "Doc, that shot didn't help." And I'll say, "Well, how's your leg doing, Betty?" She goes, "Oh, my leg's doing great, but my back still hurts." So the shot actually did help with the sciatic pain, but she may have another underlying problem, whether it's a sacroiliac joint, the facet joints. Similar things can happen in the neck. Another important distinction to know is even if the injection hasn't helped, it helps us diagnose the pain. The only real way to know for sure if somebody has a sacroiliac joint arthropathy or inflammation is to target that joint under X-ray guidance and inject it. And if the patient doesn't report any relief at all, then we can rule out that joint, because often the spine is quite complex, and imaging in and by of itself isn't enough to figure out exactly where the pain's coming from. So I'll often tell patients, don't get discouraged if we do the shot and it doesn't help, still come back, because now we'll take that joint off the table, and now it's more likely one of these other 2 to 3 things that it could be. Hopefully,
so the process of elimination is really the key. If you're still searching for more.
And hopefully with a good exam, a good history, and reviewing our diagnostic imaging, we can be more right often than we are wrong. But sometimes it's confusing, and even if you had 2 or 3 different pain specialists review, there wouldn't always be a consensus exactly whether it's a facet, whether it's the SI, whether it's just muscle spasm. So sometimes we rely on these tests to help us rule in or out where the pain's coming from. And then we can look at what's going to be the best therapy to get that patient better.
Do you often collaborate with the other docs when you have a real concern about a patient? We
do. One of the fortunate things, and I think it's great for the patients with our group and the size we have, once a month we'll get together with the doctors, the nurse practitioners, some of our doctors in Cedar City, Park City, other areas will call in, and we'll present difficult patients with a difficult diagnosis where we're struggling to find the diagnosis or the treatment, and that way we can get a lot of minds around the problem and get another angle. Another thing we're actively involved in is once a month with the SUNY Institute, which is a Southern Utah Neurological Institute, we'll meet collectively with the spine surgeons. And the spine surgeons and the pain doctors will sit down and collaborate and present patients that, do we think surgery is the best option? The surgeons may say, do you think this patient would benefit more from a radiofrequency ablation or a spinal cord stimulator? And likewise, we'll have a patient that hasn't responded, and we'll talk to the surgeons. And you may have 6 to 8 physicians around just discussing that one particular patient, which is, I think, somewhat unique that you don't necessarily get unless you're at a large academic center. So I think that's something unique to the area.
That is very impressive.
Yeah.
Very helpful.
Yeah, so that collaboration has been great, and I think building that around the patient has really, I think, led to a lot of good outcomes for a lot of patients.
Let's talk. You don't mind me asking a few questions here, but I'd like to. Let's talk about what's in the injections. What medicines are in the injections? Yeah,
absolutely. So a lot of there's a wide range of medications that can be used into the injections. More often than not, we hear of cortisone shots or steroid injections. Steroid is a very potent anti-inflammatory. So if we can inject that steroid around the nerve root or around the joint where the inflammation is, over 3 to 5 days as it starts to take effect, it can significantly reduce the inflammation. So a lot of patients will ask me about osteoporosis, or is this going to erode their bones? And we monitor the amount of steroid closely that they get. We all make steroid in our bodies through our adrenal glands, and it's a natural occurring thing in our body. We just artificially make the steroid so we can put a higher concentration where the inflammation is. And as long as we monitor how much a patient gets in a year, it's usually safe and it won't affect the bone. What I explain to my patients, what's more likely to affect your bone is if you have this ongoing pain and you can't weight bear or exercise, then the bone can start to, the muscles atrophy, the bone can not have as much load on it, which over time can lead to some osteoporosis.
So that's just as important for the patient to realize that it's important if they can exercise. They do so.
We always encourage that the patient participate in the therapy. It's not just enough to take pain pills. The goal of the shot is to reduce the inflammation so that they can then participate in physical therapy, walking, aquatherapy, yoga, Pilates, stretching. All of these things help. And what I tell my patients is if you'll do those things, it's like an insurance policy from not having to see me as often to get injections, because nobody likes to get an injection if they don't have to get an injection. The ideal route is that we get better with some of these alternative, non-invasive techniques. But unfortunately, sometimes we need to give a little extra help to reduce that inflammation so they can participate in the therapy, get more ambulatory or mobile, and help address the pain that they're having.
What about the lidocaine that you put in? You usually put that in in the injection? So
we'll usually put some lidocaine in. One, we want to get some immediate relief. If we're already in the area of the pain, the lidocaine will help numb things up a little bit, especially if somebody's got real intense pain, because the steroid initially can be a little aggravating if it gets on a raw nerve. So a little lidocaine helps numb it up. The steroid will help. As the lidocaine wears off, then the steroid starts to take effect. The other areas where we'll use lidocaine, sometimes if we're injecting a joint or the nerves for the small facet joints, we only use lidocaine because our only real interest is that where the pain is coming from. And if we numb up the nerve to the joint and that's where the pain's coming from, it has no choice but to feel better because the lidocaine is going to numb the nerve for an hour or two. It's the same as if you see a dentist. If he numbs up the right tooth, he can drill and pull. And if he numbs up the wrong tooth and starts to drill, you're going to feel it. It's not going to make any difference.
That's a good.
So we don't need steroid to get some of the diagnostic information we need because what we're working towards is the radiofrequency or something that's more definitive. Something new that doesn't involve steroid that's quite exciting is a PRP or platelet-rich plasma.
Oh, yes.
And stem cell therapy. Those are two new exciting techniques or therapies that didn't exist, or weren't available to most people until a few years ago. One, the cost was significant. So, Tiger Woods, some of these pro athletes could afford it, but for most of us, the price was just out of our reach to even consider getting the therapy. And then often they would have to go overseas to get that therapy. Now as the science has progressed, that therapy is becoming more common. It's still an evolving science. We're still waiting on some of the data, but there are a lot of practices around the country doing it, and it's like everything. It doesn't help everybody, but we've seen a lot of patients that have really done well and really responded. That's the stem cells. The PRP is in a similar class. The PRP is exciting because it's using your own cells or platelets to help promote healing. So when we get a cut or an injury, the platelets are one of the first things that are in the bloodstream that go to that area of damage, and they recognize the damage, and they send out strong signals to the rest of the body that there's a problem over here. Through the chemicals they send out and the signals they send, the other cells migrate to that region and start to help with repair. As we age, some of our joints, the blood supply isn't significant to that area, so we can trick the body by taking somebody's own blood, spinning it down, and these platelet cells will float to the top. We can extract them, and then we can inject those cells into a joint or a tendon or an area of damage, and they appear to help accelerate the healing process. And we've been excited with a lot of the results that we've seen with that.
Okay. Well, this is really interesting. I think you've covered a lot of very effective areas of discussion here. Are there any other areas that you want to talk about, or perhaps maybe conditions that cause... Oh, I had another question. What do you do differently than chiropractors?
So chiropractors focus on manipulation of the joints or soft tissue work. We don't do as much soft tissue work. We're more in the diagnostic role. All our physicians are medical doctors by training. They're board certified in either anesthesia or physical medicine rehabilitation, or one of our providers is also a radiologist. They're all fellowship trained, which means they've spent 1 year designated at an academic hospital training in interventional pain management.
That's very impressive. So how many do you have on your team right now, Doctor?
So through the state, we have 10 medical doctors and 10 nurse practitioners or physician assistants that help in delivering the care and coordinating the care of our patients. Here in St. George, we have 4 providers. We typically on any given day will have 2 doctors in the Health and Performance Center behind the hospital, 1 over in our Hurricane office and 1 over on our Sunset Clinic.
Have you ever treated someone that has a sit-down bone pain?
Yes.
Whether it's a ligament or is it a bone, I'm not sure which it is.
Often it's a bursa. So
a bursa.
Yeah,
right on their sit-down bone.
Right on the butt bone. There's a little bursa or a fluid-filled sac that leaves the pressure between the muscle and the bone, and if it becomes inflamed, it can be quite tender. I have a lot of lovely patients that'll tell me it's sometimes difficult to sit in church or on a wooden bench, and they'll put the finger right on the tush, and when I push, it's fairly tender. And usually under X-ray, it's a very simple injection with a little cortisone that gets the inflammation out of that bursa, and they usually respond very nicely and usually pretty
nice
grateful
to hear.
When the pain's gone.
That's nice to hear. Yes, that is. I've talked to several people, including myself, that have had that kind of a challenge. Thank you so much, Dr. Frieden. You've just been listening to Southwest Spine and Pain Back to Life show with Dr. Frieden, discussing a lot of different things today, but really focusing on the difference between acute pain and chronic pain. If you or your loved one is suffering from any kind of pain or discomfort, or there's a list of so many of them, call Southwest Spine and Pain at 435-656-2424. Thanks for joining us. Tune in each Monday evening, 5:30, for Southwest Spine and Pain Back to Life show.
Join us for Back to Life every Monday at 5:30 p.m. here on St. George News Radio, where board-certified physicians from Southwest Spine and Pain discuss different alternatives to live life again pain-free. For more information, go to southwestspineandpain.com.